IO and TKI, and then I want to get to some questions. We talk about these parallel tracks, targeted therapy and immunotherapy. Can we sequence them? Is there any role for IO after targeted therapies, before? Will there ever be an opportunity to use these drugs together concurrently? What are the challenges here? Is there a role for both IO plus TKI in any genotype? Do we see this playing out in clinic in real time? I know most of the data we have has shown significant toxicity by using these together. Jack, I'll start with you. Just your thoughts on if this is possible?
Well, yeah, I think that I would treat the agents and the settings as distinct. So I would not be pushing to try to integrate Tagrisso and immunotherapy. And many ALK inhibitors have led to, with immunotherapy, hepatotoxicity, liver toxicity, or other issues. So I think that there's not a compelling reason to do that in many settings, but KRAS is a different entity. And I think that potentially combining sotorasib with, or Lumakras as its trade name is, with immunotherapy could be very feasible. I wouldn't want to presume that every other targeted therapy is incompatible with immunotherapy. I think we wouldn't want to do this outside of trials, and we need to be cautious, but we shouldn't presume that it's just a categorically infeasible and bad idea. It could be that KRAS, that combination, is a very good first line approach. I would just defer that to a clinical trial first.
Yeah, Zosia, your thoughts on this?
Just briefly, I'll say I agree with Jack. I think we have enough data to say that that's probably not going to be the approach that we take with EGFR, for example. We've seen that with EGFR inhibitors and immunotherapy, the combinations can be quite, tough in terms of side effects. And I think that, probably somewhat similar with ALK, we've seen similar stories there as well. But I think Jack's point is well taken, that with some of these newer drugs, I think we can't necessarily extrapolate. They work differently. They have different side effect profiles. The patient populations are different. And I think some of these may need to still be examined carefully in clinical trials going forward. But I wouldn't do it yet outside of a clinical trial, I think.
Yeah, I would agree. And I think KRAS G12C may be the beginning of that story to understand how to evaluate synergy safely with IO and TKI moving forward. It'll be interesting to see how this all plays out in clinical trials. So we've got 2 minutes for questions. We have 2 questions here. The first question, if a patient has an oncogene-driven lung cancer, and they've tried all available TKIs and chemotherapy, would you ever recommend treating this patient with chemo IO versus just IO alone? And I guess it would depend on the genotype. Let's just make this since it's multiple TKIs, let's make this an ALK patient. This is an ALK patient who's received multiple TKIs. That's in 3rd or 4th line. Would you ever use IO alone at that point, or would you do chemo IO? Zosia, you can start here in 30 seconds or less.
Sure. I think I think assuming that they've already progressed on chemotherapy and kind of gone through those, I think I'd probably, acknowledging the limited chances of success, probably lean for IO alone. I think if they've already progressed on those chemotherapies, adding those back in with the immunotherapy, I'm not sure would be quite as helpful and may add in terms of side effects. Okay.
Jack, your thoughts?
Yeah, I just had a patient who, seemed to get some benefit from a chemo IO combination and then have had somewhat ambiguous progression. And I switched out and gave docetaxel with Pembro, and they had some good results. It's totally anecdotal. It's a pretty unusual setting. So I generally wouldn't do chemo IO, but these are all situations that maybe should be never say never, and they require a somewhat personalized approach.
Okay. One last question, which you're going to have to check yourselves because you're going to want to answer it in multiple statements here. But let's say you've got a stage 3 lung cancer patient who's EGFR positive. Is there a role for single agent IO? I'm going to make the leap here that this is post-concurrent chemoradiation. Of course, we've got Pacific showing Durva showing a survival advantage post-concurrent chemoradiation, maybe not in the subset of patients that are EGFR positive. do we still use IO in this setting? Jack, I'll give you the first crack in 20 seconds or less.
Yeah, I was previously someone who felt like, well, they were part of the trial that was positive, but I think the more data we get, the more convinced I am that there probably is not a benefit. And I've been listening to people like Zosia on this, who I think are disinclined, and unless she really surprises me now. So I'm veering away based on emerging data.
Zosia?
Jack, I won't surprise you. You know, you and I have talked about this a lot. You know, I think it's an important question, and I know that there's a lot of really, you know, smart people who look on both sides of this coin. But I am in the camp that would probably lean against immunotherapy in that situation.